Hey, hi, welcome everyone. Thank you so much for joining us today. I'm going to just get us started with a few announcements, and then we'll have a presentation by our colleagues at University of Oxford, and then we'll have a Q&A after that. So please ask any questions in the chat that you might have as the speakers are presenting. You'll also have the option to ask your question live during a Q&A session at the end. So if you'd like to do that, just indicate that your question is a live question in the chat, and then we will unmute you when the time comes when we can call on you. After that, our speakers will give a few final reflections, and then we'll close. So here's kind of the order of operations. I'm going to move into announcements for a minute. Reminder that the COP and webinars are completely free, so make sure that you are registering and inviting your colleagues. I'll send the link to sign up for the listserv in just a second. And then here we go. And make sure you join us for our next webinar, which we're still finalizing the date of, but we'll be sure to send out details as soon as possible. Next month's webinar will focus on a discussion of the role of faith-based organizations in WASH and healthcare facilities. And we'll be confirming a date and time as soon as possible. So we'll send that out in an email shortly. On that topic, we're excited to be launching a working group focused on faith-based organizations soon. So we'll do that at that next webinar. And if you're interested in joining this smaller group or potentially co-leading it, please make sure that you reach out to me. I'll drop my email in the chat in just a minute, and I will reach out with more details when they are available. Another reminder, if you have any ideas for speakers or topics, or if you have work that you'd like to share with the working group or with the COP that you'd like to highlight at a webinar or in a newsletter, feel free to email us at washingtonhcfcop@sph.unc.edu. I know that that's a lot of acronyms, so I'll make sure to share it in the chat. Yeah, and now I'm happy to pass the microphone to Dr. Sonia Hoque from the University of Oxford. Sonia, are you able to share your screen?
Yes, thank you.
Great.
Yeah,
If you can just put it in, there we go.
yeah.
Perfect.
Okay. Um, Good morning or good afternoon, everyone. I would like to present about our journey with a results-based funding model that's called SafePani, and we have piloted this model in Bangladesh. So SafePani means safe water. Pani is the Bangla word for water. And I will go through, firstly, a little bit of a trailer of what SafePani is about. Then I'll go into behind the scenes of actually what we did as researchers within our research program to ensure that this service delivery model is scaled up with government co-funding. And if you want to see the whole movie, please read my paper, the link to which will be shared at the end of my presentation. So SafePani is a model that has been developed as part of the FCDO funded REACH program, which started in 2015 and ran for 9 years till 2024. And as part of the program, when we started our research on rural drinking water services, we knew that there are certain common challenges that we face in many places across the world, and you guys are obviously familiar with these challenges. Firstly, in rural areas, we see that a community-based management model is prevalent, where publicly financed infrastructure are usually handed over to the communities for operation maintenance, and there is no monitoring or regulation thereafter. And the same goes for schools and healthcare facilities where individual administrators are responsible for their own water points. And this template of management has been developed during the MDG era, where the focus was on increasing access and infrastructure provision. But as we enter the SDG era, we are now looking into an expanded focus of indicators well beyond access. So that's what gave birth to the concept of SafePani. So we were advocating that we need to change this service delivery model from one that is community based and voluntary to one that has a professional service provider responsible for all water points within a designated area. And the government's responsibility can then shift from direct provision of services to more of a monitoring and regulatory capacity. And with this shift in service delivery, we can also get data on water quality, reliability, and so on, in addition to access, which we are normally used to. And in order to operationalize the model, we have worked on developing a results-based funding model where the service provider is paid quarterly, depending on how much they have, how much they have achieved in relation to some performance indicators. So now, what is SafePani doing in Bangladesh? In coastal Bangladesh, where we started which was one of the observatories of the REACH program, we have done a lot of research on rural drinking water services, and particularly in schools and healthcare facilities. So around 2021, we piloted this SafePani model with funding from the REACH program. And in order to pilot these model, we selected these certain areas within the Khulna district in southwestern coastal Bangladesh. And we selected Hai Sawa, which is a nonprofit organization in Bangladesh, as the service provider. I shouldn't use the word selected, but Hai Sawa was competitively awarded this contract based on an invited call. So the idea was that with this funding, Haisawa would be managing all schools and healthcare facilities within these selected areas, and they would report their service status through performance metrics that we have iterated over time. And we would have the government as part of our steering committee at the local level, at the national level, where we would continuously update them about the progress and learn about how this model can be replicated. So at the end of the pilot phase, SafePani has been taken up by the government, and it is now being scaled up to the entire district with around 1,160 schools and healthcare centers. And this time, the government is co-funding this initiative. 50% comes from government and 50% comes from Uptime Catalyst facility. And Oxford has shifted its role from more of like directly managing the project and over to more of a learning partner and provides technical assistance on this. And as part of Uptime's results-based contract, there are verification systems through which the performance indicators are verified and the funds are released to the service provider. And our estimate and also the costs incurred are less than $1 per student per year. So how did a project which piloted a model at a very small scale manage to scale this up and generate impact through government co-funding? That is what I looked into in our recently published paper, which is also co-authored by our colleague in the government of Bangladesh. Before we go into the paper, just a brief outline of what the service provider does. So when I say that they are managing 1,160 facilities, that means we first do a comprehensive assessment of the drinking water points in those areas. If any facility does not have a water point, we report that to the government because infrastructure provision is the government's mandate. And if there are existing infrastructure and if we see that they need some basic rehabilitation work to ensure that they provide the optimum service to minimize sanitary risks, we do so. Like as you can see in the photo, we raise the platform to prevent flooding and improve sanitary conditions. And then once the water point is taken on board, the service provider is responsible for not operation, I mean, in this case, repair and maintenance. They conduct regular site visits for sanitary inspection. They do one chemical testing once after onboarding the water points, and then regular E. coli testing to see whether this has fecal contamination. And if contamination is detected, then they report it to the government or the responsible authorities and also carry out disinfection immediately. Now, going behind the scenes, what is the story of change of SafePani? So as I said, SafePani started off as a research project. So earlier in the REACH program, it was, I call that phase, the research to conceptualization phase. And then based on our understanding and the partnerships that we developed with government and practitioners during that time, we moved on to piloting that model in selected areas of Khulna district. And after that, this has been scaled up with government co-funding for 6 years until 2030. But this didn't happen overnight. And when we talk about research impacts, it is vital that we need to, that is vital that we understand what are the processes that are going on in the background. So we conceptualize that um, in order for a research to have impacts, there need to be some purposive actions by the actors who are involved. In this case, it was the academics, which is us, the University of Oxford, and our partners in Bangladesh. We had practitioners and we have government agencies who are responsible. And it is through continuous interaction within these partners and through minor activities, the micro level activities on a day-to-day basis that we can ensure that research is being taken up and impacts decision making. So let's look at the first stage, which is the research to conceptualization stage and what we did here. So in the beginning, Oxford University as the lead for the REACH project partnered with the Bangladesh University of Engineering and Technology and ICDDRB in Bangladesh as research partners. And the research work focused on understanding water point access, reliability, institutional issues, and so on. And UNICEF Bangladesh was one of our research to action partners. And because we have been working in the water sector, our initial engagement started with the government's Department of Public Health and Engineering, which is responsible for providing rural drinking water services. And the agency, under the national policy of 1998, is mandated to provide infrastructure access. But it was only in 2024 that a national O&M strategy was released. But as you can see, it is a strategy and it is more of a guiding principle rather than being operational at the local level. But when we started our work, our thoughts and perceptions were around a reliability-centered maintenance model. Because previously there we had projects in Kenya led by Oxford University where and we had this Fundifix model in Kenya, which was more focused on reliability of hand pumps to ensure that when a hand pump is broken down, there is a professional service provider who goes in and ensures that it is repaired in a certain amount of time. And we also our colleagues also installed automated data loggers on hand pumps to monitor breakdown. So our idea was actually transferred from that Kenyan context to Bangladesh context during that time. But with as we gained more knowledge, more contextual knowledge, we realized that only reliability or maintenance may not be what Bangladesh needs because the context is very different. Bangladesh is a country of 160 million people with 18 million hand pumps, which means every other household has a hand pump. And operation and maintenance for a hand pump is something that the private sector or households or local supply chains have addressed over time. So what we realized that in this country where there is plenty of water, but the water may not be of good quality, water safety has to be an integral aspect of service delivery. So we started some seasonal water quality monitoring across all the different water points. And when we were thinking of piloting the SafePani model, we realized that our go-to government agency shouldn't be DPHE. We should go to public administration because of the political leverage they have and the all the connections from national to local local level. So we went to our partnerships started to expand with the local government division. And instead of going to community hand pumps, which are more politically sensitive to manage and difficult because there are a number of different stakeholders involved, we realized that schools and healthcare facilities might be a good entry point because DPHE is mandated to provide drinking water in all public primary schools. The responsibility is a bit more fuzzy for secondary schools and healthcare facilities, but since these are government institutions, the government can be held accountable for these services. So our engagement with the government involved a lot of activities which ensured that we build these networks, we frame the SafePani model, and we take government on board. So during this time, we published a number of reports with government co-authorship along with our research partners in Bangladesh. We tried to I would say, as I mentioned in my paper, is we construct normative frameworks and normative associations around these rural water services so that we can legitimize this new governance model. So that one day next, when we come to pilot this model, we have a strong foundation for that. In the pilot phase, with the same partners, we now had Sava, the service provider, on board, which is again a practitioner. But in this case, we tried to further strengthen the institutions related to monitoring and regulation. And as you can see in the photo, this was the SafePani Inception workshop in Istanbul, which was attended by a number of high-level government people. And they are signing the additional secretary of local government division who was made the chairman of the National Steering Committee, is signing the SafePani pilot agreement here. So we had two government committees, the National Steering Committee and as well as the district working group led by the Khulna district administration at local level. And Sava was responsible for all the field operations reporting, and Oxford ensured that we provide technical assistance in co-developing this piece of work. So if we look at our purposive actions during this time, it was more about defining the rules and rules, roles, and responsibilities, and building the capacity in the ground so that if we want to extend this later on, we know who will do what role the government needs to play. We need to ensure that all government entities are aware of this, and there is a high appetite for this in later stages. And finally, when we went to the scale up phase, so it was a very important stage because we are asking the government to co-fund this initiative. Now, although the cost implications, the total cost for the SafePani model in Khulna district is estimated around 2.1 million USD over the 6 years. And this money is nothing for a government. But in order to make sure that this is being taken up by government, it is vital that we had within the government individuals who were really motivated and could leverage their networks. So the person, the additional secretary of LGD, who was there in the beginning, he was really on board with this model. But because of staff rotation, for a period of time, he was in a different department, which created a bit of delay in processes. But luckily for us, he returned to LGD and now in a higher position, in a more senior position as secretary, which was really important in leveraging his power to ensure that the model is integrated in government funding. And as we were trying to turn this into a results-based funding model, of course, we had Uptime coming in. Um, Uptime has been doing results-based funding in different countries across the world over time. And they had all the mechanisms set up. How do we do the reporting? How can we pay the service provider? And Uptime also leveraged their fundraising capacity because 50% is being funded through Uptime Catalyst facility. So at this stage, the purposive actions were more about advocacy and finalizing all these indicators, payment triggers, and also making sure that SafePani is institutionalized as a scalable model rather than a short-term project which ends with the REACH program. So the REACH program ended in 24, but the model is still there. It's operational across Khulna as of now. And in the picture, you can see we have a new secretary now of LGD who recently, along with his other colleagues in the government, visited the study sites. So we are trying to build in this institutional memory so that we can further scale up SafePani probably to different districts and hopefully for the entire country. And so with that, I will end my talk here. And this is the paper where I have written up all of these in very good academic jargon. So you can use this QR code to access the paper. And I will now stop sharing and hand over to Katrina. Thank you.
Thanks very much, Sonia. So what I'm going to shift to now is to share a little bit more about the water safety aspects, and particularly thinking about this in the context of WashFit programming as well. So what we so if I look at this is from the WashFit implementation case studies from 2022. So for Bangladesh, it says, despite promising improvements observed in most of the healthcare facilities, there were challenges in sustaining them. An absence of sustainable financing for the operation and maintenance of facilities and services, and lack of engagement of wash sector partners in the process were major barriers for improving wash facilities and services. And so that's the quote from the Bangladesh case study, and it highlights the gap that was there before SafePani started within these sectors. As Sonia highlighted, we're working both in schools and healthcare facilities, but across a whole district area, and able to ensure that we are able to sustain these impacts. So I'll give you a little bit more depth on the water safety side, as I said. And so in this, the work we do, it draws from both the guidelines for drinking water quality and the approach there for small water supplies, a water safety planning approach, and then aligns well with the WashFit model as well. And so if we look at the 8 steps, the area we're particularly focused on with the work we do in SafePani is the steps 4 and 5 around improving and maintaining infrastructure, and then monitoring and reviewing data. And so at the moment, the SafePani model is only focused on drinking water with the approach of trying to make sure we can get that working well within the model. We've recognized that WashFit and other approaches, there's always more other things to do, but the idea with the model is certainly to get it working well for water initially. And I should say that SafePani also does contribute to those others, and as you've heard from Sonia, there is engagement across the stakeholders and that contribute to these other areas of the 8 practical steps as well. And so I'm sure many of you are familiar with this from WashFit, of this this cycle that is at the core of so much of what we do in WASH. So the same with water safety planning, the same with in healthcare facilities as well, and continuous improvement cycles. So we see throughout the different parts of the sector how we want people to be learning to assess the facility, to work together to improve and to improve the outcomes. And so this is very much the approach that's at the heart of what we're doing in SafePani with water safety as well. One of the key ways that we're implementing this type of continuous improvement approach is to shift it from the facility level to the district scale. And so that's particularly the service providers who are working at that district scale to serve all the healthcare facilities, and in this case, schools as well, recognizing that the individual facilities will have low capacity, low resources, and Sonia highlighted the budgets aren't there necessarily to make the improvements that are needed. So we can take that risk prioritization step and take it up to a district level rather than implementing that the single site level. And then, of course, the team that we're establishing has that professional service provider who works with each of the facilities, but it also, they also engage very closely with the healthcare facility managers, and I'll talk more about how they report to them and communicate with them, but also working closely with stakeholders across Ministry of Health at different scales and other ministries that are relevant to the delivery of safe water services. So I'll take you through step by step the way we implement this with the service providers. And so there are a number of steps. So the assessment stage includes both aspects of the system assessment. We use sanitary inspections and water quality sampling as well. And so what I'm going to highlight here is the way we use the results-based funding to incentivize improvements, but also to incentivize that continuous improvement cycle to progress as well. So for the start, the service providers will perform a sanitary inspection to understand if the conditions are good or poor. And so importantly, where the conditions are poor, remedial actions are taken to address those hazards. And so the systems need to achieve a certain level of low risk before payments are going to be provided. And the other aspect, whether it's good condition or bad condition, is they then report those results back to the community and the government, so that in this case, the community is the healthcare facility manager, so that they can take the necessary steps to ensure water safety is protected and act on the local issues, and also the government, so they can understand the more strategic needs around water safety improvements and the things that are beyond what a service provider can deliver as well. When the system has achieved good status, it then proceeds to the water quality sample. In this case, we're looking firstly at E. coli, but we do consider chemistry as well. And so where E. coli is detected, where a risk, a hazard is detected, again, we have the same responsive managed actions, and there's a timeline for this. So they need to respond quickly, so report to that healthcare facility manager and within 3 days, and then take a managed action within a week to treat and try to reduce that contamination. And then they retest. If they've been through that process, you don't retest until you've actually taken an action and done something that will change the outcome. And again, once you get to no E. coli detected, it's reported to the facility manager and to government. So that gives us some cycles of improvements already. But this doesn't just happen once. This is happening over a regular period, and part of that relates to the payments. So there are two tiers. The first tier of payment with results-based funding that Uptime and the government of Bangladesh provide is based on doing these actions, not on the results that come out of them. So they do need to be good condition in terms of sanitary inspection, but it's more about the actions they have taken to assess and to report those results. So they've been through all these processes. There's an additional level of payment if they've managed to get it to no E. coli, like if it's sufficiently high quality that no E. coli is being detected. And that may include that they've taken managed actions to treat that contamination so that they, within their time frame stipulated, so that the set water being delivered is free from E. coli. So the other, I mentioned already that, the results-based funding helps to incentivize that cycle, the repeating of this. So this is done at, the payment cycles are 3 months, but some of these actions are only every 6 months, so that we're encouraging repeated improvements over time and also capturing seasonal variability. And the second part to that is Uptime work very closely with the government of Bangladesh and the service providers to ensure that the results are validated and verified as well, to give the government confidence in that the results are being delivered as reported. In the Bangladesh context, these are the kinds of systems where we're working with. So healthcare facilities, primary healthcare in rural areas with small water systems. So these are commonly hand pumps on tube wells or rainwater harvesting systems. In this setting, we're not looking at complex water systems. So drinking water is also the water for patient use, and there's no differentiation on those aspects. For those who aren't familiar with the Bangladesh context, these are areas which are prone to flooding. There are lots of issues of saline water, as well as some geogenic chemical contamination with arsenic and manganese. And in the dry season, the fresh water can be quite scarce. So these water systems and their reliability is really critical to the functioning of these healthcare settings. And there's also a lot of sometimes tension with the communities, because the communities also want to access this water as well. And our service provider in Bangladesh is HCFs, as Sonia mentioned. So if we look at the results quickly, so these are just some indications of the kind of changes we're seeing over time. So this is the sanitary conditions, so based on sanitary inspections in these, in all systems. So these is data since 2022, and over that time we've had quite an expansion in the number of systems. And so what this is showing is by visit. So some systems have had up to 8 visits, and this is schools and healthcare facilities lumped in together as well. Healthcare facilities are a much smaller proportion of the total number of systems that we're working with. But one of the key things from here is to look on the left-hand side where hand pumps, you can see the increase in the number of systems which have low risk hand pumps over the number of visits. So we're seeing improvements continuing over time with those. We don't see the same with rainwater harvesting systems, and this is one of the points of learning that doing this over time has allowed, and not just us, but also the service provider and the government to understand the limitations of rainwater systems in terms of water quality and sanitary inspection risk. And so with these sanitary inspection risks, for example, they are much more seasonal and depend on, for example, the catchment area being kept clean for rainwater harvesting. If we look at the results for E. coli, so again, as I was saying, for rainwater harvesting systems, they are not as performing as well. We're seeing E. coli more often, more actions are needed to keep them safe. Hand pumps are typically safer in terms of water quality. And in Bangladesh, with SafePani, we've been able to achieve that all the actions are taken. So while we're detecting E. coli, the service provider is taking actions and learning how to make more systematic improvements to these systems. So one of the things we're looking at the moment is disinfection systems in rainwater harvesting systems to help to reduce those the E. coli detection further. By comparison, this is from Zambia, so another where we've been working with Uptime more recently. Similar setting, working with schools and healthcare facilities, but this was just in the first year. And so here you see there's more E. coli being detected. It hasn't yet reduced as much as we've achieved in Bangladesh. And we're still working with a service provider, or we were when I was analysed this data, to build their capacity to act on those results quickly to ensure safe water. So just to summarize, and I think what I wanted to highlight with these results is that, with the results-based funding, we're able to incentivize this continuous improvement cycles that are so critical to wash fit and other approaches within the sector, and sustain them over time, because there are financial incentives for the service providers to continue that work, to lead that work. These are helping to learn how to advance water safety in the context, working out what are the critical aspects for those. And part of that is improvements to promote climate resilience. So the service provider, has then collected data on issues around rainwater harvesting tanks running out before the end of the season, and working with the facilities to think about how they can improve communication, how they can improve the tools they have at their disposal to help manage that. They're looking at raising plinths, or they have been raising plinths in about 70 systems where they know there's flood hazards in those areas, and taking other actions like that as well. And as I said, thinking about chlorination, thinking about the next steps to continue to improve water safety in their settings. And then, of course, as I said, this is focused on small rural clinics. There's more work to be done to adapt it to larger facilities where you have water for healthcare use that's different from drinking water. So at the moment, Uptime just focus on one water source, so focused on drinking water source. We're aware in more complex healthcare facilities, you end up with pipe networks which require different approaches at times, and more consideration of opportunistic pathogens as well. And so some of you may have heard Leanne Ong's talk previously, who's been doing work in Bangladesh hospitals, so much bigger, more complex water systems, on some of the water safety aspects. So with that, I will finish there. So thank you very much, and we can open for questions. We also have Andrew Armstrong here with us, who is on the Uptime side, who can speak more to the validation and verification processes, and also to the results-based funding and how and Uptime's role.
Thank you so much to both of you for your presentations. That was fantastic. And we already have 3 questions in the chat, so this is great. To attendees, if you have questions for our speakers, please feel free to put it in the Q&A portion. And if you want to ask it live, just put in parentheses live question, and I'll make sure to take you off of mute. But the first question is for Dr. Charles. So it says, how do you believe E. coli is being introduced in rainwater systems? Is this a storage issue?
So E. coli in rainwater systems is being washed in every time there's a rainfall event, effectively, that anything that lands on the roof, so any animal feces, any animal behavior, can just be washed into the system. So once it's in the tank, it can then grow, because these are typically warm warm areas, so you can also get growth of them. What we see with what we've seen in Bangladesh, where we have shock chlorination in hand pumps and tube wells, is that that's really good at getting rid of the E. coli, and we've never had an instance where it comes back. So it's been successful. Rainwater harvesting tanks, though, next rainfall, more contamination can be washed in, and you can have the same issue again, even with successful shock chlorination.
Got it. And actually, there's a similar question on the topic of the E. coli results. This is from Lara Lambert. It says,
Yes.
on the slide on results and achievements, can you clarify if those E. coli results were pre-action taken or post-action taken for all water
Yeah.
delivery types?
So all those results were pre-action. So that's just showing the frequency with which we're actually seeing E. coli in that first sample in those different sites. So as I said, in Bangladesh, it's actually quite low throughout now, particularly in those tube wells, as I said, because of the success of the shock chlorination and the sanitary inspection approach. Whereas and we know that that has different effect in different contexts for a few different reasons. Um, yes, and so the post-action taken, they were all free from E. coli.
Fantastic. And there's one more question so far in the Q&A. So it says, for Dr. Hoque, this one, I understood that SafePani has achieved a 50-50 financing structure where government covers half of OpEx and the remaining half is financed through a results-based funding mechanism via Uptime. Could you say a bit more about the results-based financing mechanism, particularly the terms and duration of the arrangement? And what's the plan for financing once this arrangement ends?
Yeah, I mean, thank you really for this question. But I can answer this, but I would pass this to Andrew because he looks at all the data and he knows very well what is the funding mechanism. So Andrew, if you can please answer this.
Sure. Thanks, Sonia. And I'll say a few things and then may toss the ball back to you as well. So, hi everyone. My name's Andrew Armstrong. I work with Uptime. Part of the reason why we wanted Sonia to present the story of change of SafePani is because the funding arrangement has really evolved over time, and it was built on initially a program funded by FCDO called REACH, multi-year research program. The results-based funding arrangement, 50% coming from the government and 50% coming from Uptime Catalyst Facility, was really built on the evidence that was generated and the knowledge that was generated from REACH. The initial arrangement with what I think Sonia called the pilot phase, where in one district, half the funding is coming from the government and half the funding is coming from Uptime Catalyst Facility, was just it was a 1-year arrangement just to demonstrate how this contracting mechanism could work.
Sorry, Andrew.
Actually,
I mean,
no, I take it.
during
It was longer
yeah.
than 1 year. It was sorry.
No, I mean, during the pilot phase, it was totally FCDO funded.
Sure. Yes. Okay.
Unlike Zambia. Yeah. So, but I think what you can explain more is what are the payment indicators and how
Sure.
are the funds released based on those indicators and quarterly and so on.
Okay. Yeah, I'll mention that. Or I'll get to that. The commitment of this 50% funding is actually through 2030. So when Uptime came in and started providing 50% of the funding and the government started providing 50% of the funding, the commitment went from 2025 through 2030. So that meant that the Uptime Catalyst Facility and the government had to have a line of sight funding for 5 years. Where we are in negotiation, and that's for one district. Where we are in negotiation now is to scale up this funding to other districts. And that funding from the government is we're looking at a large government program that funds education in Bangladesh. And Uptime Callus facility is looking for funding to bring 50% of that funding at the larger scale. So we're moving from hundreds of thousands of dollars to millions of dollars needing for the co-funding on that. The long-term arrangement, I think, which is the kind of key question here, is, I mean, the expectation on both Uptime's part and the government's part is that the funding would come from the government. And the government recognizes this, but what the co-funding arrangement is doing is helping to mitigate the risk, and to continue demonstrating how this can work at scale, as well as the academic partners coming in and looking at how much this is costing and proving, that this is what this could look like at scale. So with all the partners involved, we're sort of mitigating the risk to government engagement all along the way. I think that was the point that I wanted to make. And Sonia, you can clarify anything that I've said or correct anything I've said on that side. I'm very happy to also talk about the contract cycle, maybe after that. So Sonia, I'll pass it to you if you've got anything to add, and then we can talk about how the contracting works with the metrics
No,
and the
and you
payment.
explained very well. We can go on to the contract cycle. I
Okay.
think yeah, thank you.
Um, Katrina, do you have a that slide that we added, I think, at the end of your presentation? There we go. So just a bit about how the contract works. Um, so the three metrics that payments are based on is uptime. So HiSal is allowed 48 hours of downtime. Any water point that is broken down for longer than 48 hours is disqualified from payment. They have to have low sanitary risk, and results have to be, and E. coli has to be assessed. Those results have to be reported to government, and then so first payment is for the breakdown and low risk. Second payment is for assessing water quality and reporting to government, and the third payment is for E. coli being managed, and there's no E. coli in the water. So what Haisawa does on a quarterly basis is they submit data to us, and we compare those results to their historical performance. And if the performance looks good, then we tell the government how much to pay, and then we tell Uptime Callus facility how much to pay, and those payments are issued on a quarterly basis. And then on an annual cycle, we do visits and a data audit to confirm that the results that were reported to us were accurate. And this diagram sort of illustrates that cycle, the process. And so payments are issued every quarter, but they're verified on an annual basis. I think there's more questions coming in, Nikki, so I won't talk anymore.
Yeah, there are two quick related questions, like related to each other, not to this as much. We're moving on back to kind of water quality specifically. So this is from Kunal Pardeshi, and it's a question about, did floodwater impact water quality every time, and how were salinity issues addressed since its influence of seawater intrusion into groundwater?
Thanks. Thanks for the questions. I think so. In the context in Bangladesh, there's often, as I said, there are big flood issues, but generally they've been able to increase the plinths so that the hand pumps aren't being inundated too regularly with flood water. But there can be certainly storm surges, and so the service provider works to help the facilities have the tools they need to get their water system back online as soon as possible if they're inundated in a storm surge event. So there are extra actions they take to support preparedness on that side. The salinity, it is a big challenge in the area, so it is beyond the remit of the service provider to provide new treatments, especially RO and other things that will address salinity. And there is a lack of deep groundwater, which is fresh as well in many of these areas. So they are reliant on rainwater harvesting or RO systems. So what the service provider does is they do measure electrical conductivity, and they do send that to the lab for chloride testing when it's above a certain threshold that's been identified for the region, to help the government to get a better understanding of the impact of salinity on different water supplies in the area. So there's that feedback to government to help them to manage those challenges more broadly. And then the service provider does do, as I said, work to manage rainwater harvesting volumes. They do also do sanitary inspections and manage some reverse osmosis systems that have been put in. And so they are also helping to support systems which are making water available, which is low salinity.
Great. Thank you so much. I think that actually the timing works out perfectly. So we are just going to go back to the speakers for a few. If you have any wrap-up comments or reflections, maybe we can go in order of appearance. So we can start with Dr. Hoque and then Dr. Charles and then Dr. Armstrong.
Um, I'm afraid, I'm happy to answer questions, but in terms of reflections, I think what we are looking at now is, as Andrew mentioned, is scaling up this model first to just another district where we have already done the baseline assessment, and then to the entire country as well. And we are doing parallel work in Zambia, so which is following a very similar template as to what we did in Bangladesh, and again with the government and Uptime Catalyst facility. Katrina.
Yeah, so I think we've got those lessons in work with service providers more broadly on these approaches to help improve them internationally as well. I guess a couple of things for healthcare facilities in particular. I mean, in Bangladesh, we were seeing different challenges in healthcare facilities because of the types of well, just having less land makes it difficult for them to have water systems built on them. And then within the water facility at the moment, as I said, we're dealing just with drinking water. And that in those small systems is fine because that's water for everything and water for hygiene and water for health, all the healthcare uses. And it gets more complex as the complexity of the hospital or healthcare system increases. So as you see with the rainwater harvesting tanks, they are more challenging to measure. And we know we get to pipe systems, there are different things to consider in terms of water safety, in terms of storage tank. How hot is the storage tank? Is it in full sun? How is the water quality in that system being managed as well? But it does, we are finding it very promising that we can start to see that continuous improvement cycles, that they are happening and we are seeing improvements sustained and increased over years.
Fantastic. And Andrew, any final comments?
Thanks, Nikki. I think I have maybe three transferable lessons that I think would be helpful for this audience. The first is around the contract design. When Sonia and Katrina were mentioning professionalized service delivery for institutions, often I'm an engineer. I have a background in engineering. Oftentimes, engineers want to overcomplicate things, and it's very often that we say, "Oh, well, all these things are important. We'll end up with 15 performance indicators that we're trying to monitor and measure." And what we've really tried to do with Uptime, those who are on the call that have been involved can attest to this. We tried to simplify the metrics that we're monitoring against, so that incentive payments can be made against those metrics, and the actually performance can be understood how it influences the payments. Okay. So really, we're only tracking and simplifying the data systems too, so that we can verify it easily. So we're only tracking uptime, we're only tracking sanitary inspections, and we're only tracking E. coli testing and reporting those results. There's a host of other things you can measure, but we're only tracking those things. And so I think that's really a transferable lesson, is to try and simplify it as much as possible, because if it takes you longer than 5 minutes to explain it, government is going to just sort of pass on it. The other thing that I think is really important for this audience is linking public institutions. So healthcare facilities is a big part of this, but we're also doing it in public schools. And what that allows us to do is scale the service delivery opportunity. So the professional service provider can get enough water points so that they can actually, cover, make a living off of this. It also opens up the door to fund and finance this through different channels, government channels. So with Bangladesh, we're looking at education to fund this at scale rather than, health department, health ministry. And then the last thing I'll say is just that this building on evidence and sort of at each stage of the way when you're trying to do something at a large scale, sharing the risk with government. So pointing back to what you've done, every stage you've sort of continued to invest, continued to co-fund, and then, but also before you get to the next phase, make sure that you get government commitment before you just sort of go out and get donor funding and do the next thing. So you have to sort of stopgate every bit of the way to make sure that that you're not just getting ahead of government, and also that you're providing enough evidence to the government so that they can go out and get the co-funding or the funding to do this at scale. I think those are the three things I would highlight.
Thank you so much.
Yeah.
And I've put a few resources in the chat, so I'll give everyone a few seconds to kind of locate those that this team has shared if you want to learn more about SafePani and Uptime. And yeah, I think that's going to be it for today. So thank you so much to everyone who joined. And once again, please stay tuned for an announcement of our next webinar in March. And yeah, see you next month then. Thank you all.
Thanks very much.
Thanks, everyone.
Thank you. Bye.